Share screen, go back. Should come up there. Excuse me, just get the right thing. Come on, come on. Okay, so the second half. So we're going to look basically with PET. First of all, with some other diseases with FDG, and then look at some non-FDG PET. And there's some interesting agents coming along. So we're going to talk about solid tumors, other solid tumors, not lung. So that's things like esophagus, colon, melanoma, and some other ones as well. So esophageal, recommended use. We don't really use it to do the tumor staging because we're not precise enough in terms of actual size, and often the primary can be very thin in the esophagus, so it's best for that to be done by EUS. For nodal staging, we may miss some small nodes next to the primary, and again, EUS is very good with that, but we're good at finding nodes away from the primary. And again, with the TNM staging, TNM8, 1 to 2 nodes is N1, 3 to 6 nodes is N2, and more than 6 nodes is N3, as we said in the gastro talk yesterday. PET is the best for finding malignant staging, and obviously in recurrence. So I haven't got many because we discussed it yesterday. Here, for example, is a patient who has an esophageal primary. You can see quite a bulky primary here on the MIP image. And here you have a couple of lung, liver. There's a little peritoneal nodule, which is hot just by the peritoneum, and here you have a liver metastasis. So this is, even though there's very small volume nodal disease, in fact it was N0, it is an M1, so it's inoperable. Sorry, I just got to get some work. This one we thought was a recurrence. This patient's had an esophagectomy and has had a pull-up of the stomach into the chest, and was starting to get problems with swallowing. And we thought this was due to possibly recurrence. We did an FDG PET scan, and this looked horrible. Here's the pull-up of the stomach in the chest, and there's this, we thought, oh grief, what's going on here? Looks like the tumor's gone back into the lung. It was a horrible, horrible recurrence. So this was biopsied, and actually came up, what had happened is the poor patient had got a gastric ulcer in their stomach pull-up, and it had perforated back, and it was just an infection in the lung. And with some H2 antagonists and some antibiotics, the whole thing cleared up and the patient's symptoms disappeared. So just a reminder again, even in query recurrence, is that FDG is a non-specific tracer and may pick up inflammation as well as tumor. The stomach itself, FDG tends to have a bit more of a limited role, and part of the problem is that some stomach primaries can have very low levels of FDG, and it can be difficult to see. And so you can only really use it for staging if the primary site is negative. So I've got an example here. This is the primary, and this is the stomach wall here. It's not very well prepped, but you can see a very low level of uptake here, and that makes it very difficult. The SUV max is only 1.8. And here is a really big, chunky gastric node. It's around about 2.5 centimeters, but there's no uptake you can see of FDG, and that's because it's one of those gastric cancers that has very low uptake. So it's clearly positive. It's clearly, unfortunately, this patient has got big nodal disease, but FDG is not really helpful. However, in some cases it can be. This was a patient that was scanned for cancer of unknown origin, and we got here a linitis plastica with diffuse uptake through a thickened wall around the stomach, which is very FDG avid. Other areas we can use FDG: colon cancer. We've tried multiple times to see whether or not we can use FDG to stage the primary site, but it's proved that it doesn't seem to be any better than the combination of CT and in the pelvis MR. So it's been difficult to justify the additional cost. Some patients we've still done in bulky tumors because we can find some nodal disease. It's just not good for every patient. However, one of the other issues, that, as you all know, because you've all done lots and lots of FDG PET scanning, is that we often see focal uptake of FDG in the colon. So is this another cancer? And the problem is that colon cancer is a common cancer, so it may be seen in many patients. So one of the things that we sometimes see is an unexpected uptake, which can be colon cancer. Again, the problem with nodal disease is that it can be very close to the primary. If you've got a big chunky primary, you might obscure lymph nodes, but it is very good for more distant lymph node disease and liver disease. And after treatment, we find it very useful in patients who have a rising CEA. So this is the classical situation. You get this patient was scanned for another reason, but has focal uptake in their colon. How many times have we seen that? So here we have in the splenic flexure, a single site of uptake. Is that cancer? Is it an adenoma? Well, you can't tell with PET. So this patient has earned themselves a colonoscopy. Stage and liver metastases. This is a very good use for FDG PET in CA colon. MR might be quite good for finding small liver lesions, but sometimes we find them in PET. We don't find them in MR. And certainly, if you look again at modern PET scanners, they pretty well find the same lesions as MR. But also what we can then do is exclude any extrahepatic disease. And the thing you worry about in patients who've got liver mets is they can quite commonly get lung metastasis. And if the primary is still in sight, and bizarrely sometimes they do treat the liver mets when the primary is still in sight, then again you can look for other nodal disease. And you can also scan patients before and after the chemotherapy that's sometimes used to shrink the tumor before they go for surgery, either the primary or the liver metastasis, called neoadjuvant chemotherapy. This is a fairly early study looking at 1,000 patients that were scanned with CA colon metastasis. This was published in the journal Cancer, again a good journal, and found that the overall sensitivity was about 88%. And the only things that really missed were small lymph nodes next to primary. The specificity was also very high at 96%. It was slightly less for liver metastasis, but this was done really without time of flight PET-CT. Once we've got time of flight PET-CT, that sensitivity probably rolls up to around about 90%. And a little bit of issue with specificity, but again, with time of flight, that's really been improved as well. And the conclusion was that it was the best method for looking for extrahepatic disease. So here we have a fairly simple one to identify. This is a patient who has a large single liver metastasis. We don't find anything else on the PET scan outside the liver. This patient has actually already had their primary removed. So this patient can now have a liver resection. And we know that makes a significant difference to outcomes. This is a patient who we weren't sure what was happening, but this patient had a primary in ascending colon by their hepatic flexure. And here you can see intense uptake in the primary tumor, but it actually has directly invaded the liver. So this patient had a sort of large operation, which they took out the primary, and they can see there's a little lymph node here, but they also removed, that's a mesenteric lymph node. And then they sort of debrided the liver, but they were able to preserve most of the liver, and this patient did very well. Looking at recurrence, we may do it because we see a suspicious mass on CT or suspicious change on CT, or there may be a rising CEA level. But again, remember that FDG is not specific, and you may get uptake in the colon or in sites of inflammation. Sorry. So here we have a patient who has had a colostomy for as part. So what tends to happen is that patients with large recurrences will have remove a bit of the colon. They may have a defunctioning colostomy, and then at some point in the future, if they remain disease-free, they may then have that colostomy reversed. Now, this patient was planning for that, and we did actually see a liver met. You can see there's just a liver met on the MIP image, but then had this FDG uptake at the back of the colostomy. Now, what is that? Is that due to recurrent tumor or residual tumor, or is that just due to inflammation? And you just don't know. So in the end, what we planned to do with this patient, we took out the liver met, and then we reversed the colostomy, but we took out a chunk of tissue at the back of the colostomy. And at histology, this was just residual inflammation. Now, fortunately, there was no tumor present, and the patient did very well. So there has been some reviews. This was a review that was done from a Turkish hospital looking at patients who have just elevated CEA and a negative CT. And they confirmed the uptake compared to biopsy, and they found the sensitivity was high, nearly 100%, but the specificity was low because there were post-operative inflammatory conditions which could last for months or years. And I think as long as everybody's aware of that, then that's fine, because I think most patients will say, if there's any doubt, please just remove it. And if it proves to be inflammation, then that's sort of good news in a way, isn't it? Because that means they don't have recurrent cancer. And there is some evidence that some patients who have inflammatory conditions in their bowel may have moderately raised CEA. So you may solve the problem by removing that part. So here is that patient that we saw before with a single liver metastasis. This is the image of the liver. And this patient, as I say, could go on for, and they could just do like what we call a wedge resection there. So, and that can be done by a laparoscope. They don't even do an open operation anymore for removing these small liver mets. So PET really helps in that. What about melanoma? We can use this in primary staging. The role of that is still a bit controversial, but I think we're more and more now in any patient who has a high risk primary, we're doing preoperative staging because we don't want any surprises. And any patient with a positive sentinel node, we're pretty well doing FDG PET now. Even though, I mean, some of the literature is not particularly brilliant. This is from radiation oncology, looking at 322 patients, 51 patients had a positive FDG, but only 37 of those were found to be melanoma in the positive site. But when you think about it, that's still pretty good, because we know with melanoma, the better operation you do and the more cancer you clear, the better the overall survival at 5 and 10 years. There were, of the negative patients, 20% of them still had metastatic disease at 20 years. So again, a negative study doesn't totally rule out Mets, because they may just be too small for us to see. So the sensitivity in small tumors is low, and most people therefore won't do a PET CT, but it does increase with those that have much more significant disease, stage 3 and 4 disease. And again, we've improved the quality of PET CT imaging with things like time of flight. A meta-analysis was done, and it showed at that time that for staging of early disease, sentinel node was better than PET CT. And that makes some sense, because at this stage, the disease is going to tend to be just in the sentinel node. But we do know that melanoma is not the best technique with sentinel node compared to breast, that we only get around a 95% sensitivity as against a 98% in breast, which means that there's about a 3% difference. Now, that doesn't mean a lot, except if you're doing 200 or 300 melanoma patients a year, that means you'll be having 10 patients a year where you'll be missing things with sentinel node, and they will need to go on and have PET scanning. So you just need to be aware of that. And I think slowly things are beginning to change, but some of them, the more recent data is looking at quite high sensitivities, and melanoma, when it's positive, tends to be very, very positive. So we produced some guidelines. We said that at the moment, the evidence for initial staging wasn't particularly good, but we did feel that there was an indication for staging when patients have had chemo and immunotherapy. So we know these patients are in the metastatic group. Any funny unidentified things on CT that looks like metastasis, or if there is a patients with just a few melanoma metastases tend to have surgery than immunotherapy. So just to make sure there's no nasty surprises, we suggest FDG PET before that surgery. But the other thing is expect the unexpected. We know that patients can get metastases 20 years after they've been told they're cured. So any melanoma patient that has had surgery should go. You should do a PET scan if it looks like they could be having any kind of disease up to 20 years after. And there is a big research project running in the UK at the moment where a group of patients who've had high-risk primaries, even though they look like they're all cured, are now having annual PET CT scans for a decade to see whether or not, A, we can pick up metastasis, and B, about what time interval we should be doing those PET CTs. So this was one of our patients who had had a melanoma on their leg 20 years previously and re-presented with a lump in their neck. We did an FDG PET study, and you can see that there is quite significant active disease up here in these nodes. Now, what do you do? Well, what we did was we took them out with surgery, and we re-scanned the patient on multiple times, and we found that there's no further recurrent disease. Maybe in 20 years' time, they'll get some more. We don't know. With stage 3 and 4 disease, then clearly PET is much more useful, and in the majority of patients it tends to be positive and can be used to guide further surgery. There was one false positive patient, false positive patient, but these are rare in melanoma patients. But like anything, remember that FDG is a non-specific agent. This is a patient who turned up with anemia and a history of melanoma, and you can see they've got extensive bone metastases. It almost looks like a bone scan. There's so much disease. This patient also had disease in their omentum. So this patient is probably not going to do very well, unfortunately. Paper from Germany looked at 156 patients with suspected recurrent melanoma, imaged with FDG PET. The sensitivity was lowest in the lungs at 92%, but still pretty good. And was thought to be related to the size of the metastasis. Bone metastases seem to work really well with FDG. CT was a little bit better in the lungs because it could find tiny nodules, but again, a lot of oncologists no longer treat nodules less than a centimeter, and then we can find them with FDG. So probably any disease that needs treatment you would find with FDG. So this is a patient who has small volume disease. This patient again had a melanoma in their leg, represented a couple of years later, and they're just with this bulky mass around the aorta. We've done an FDG scan, and there's 2 small nodes. And again, this patient went on to have all those nodes stripped out from that area and has continued to then have a negative FDG scan afterwards. Just to finish off this section, it sometimes can be more complex. This is a 56-year-old woman who had a melanoma in the right foot that was initially treated with excision and local radiotherapy, but then represented 6 months with a swollen right leg. So what's going on? And the problem is, of course, is that you can get all sorts of things going on, including you can get lymphedema related to the fact that she had some lymph nodes taken out of her groin as part of the sentinel node process, and we didn't know what was happening. So we did an FDG PET scan, and you can see here that there is a swollen leg. And here we got uptake in the skin, and that was biopsied, and it was found to be due to a cellulitis because lymphodematous legs can get infected easily. And there was a big hot popliteal lymph node. So was that due to cellulitis? No, it was actually due to malignant melanoma. So you can have more than one process going on in one patient. So just be aware of all these different processes that can occur. Last bit I'm going to talk about FDG this time, I'll talk a little bit more about it next year, is in cancer of unknown primary. Now we know that FDG is pretty good at most cancers except for neuroendocrines and prostate and maybe a little bit of HCC. And if the tumor is more than about a cubic centimeter, we will pick it up. And diagnosis may be found by identifying the site of disease, but also we may find odd secondaries. We've had things like breast and colon secondaries and primaries, and sometimes it's difficult to tell what's the secondary and the primary. If you find uptake in the breast and you biopsy and it comes back adenocarcinoma, was that a breast primary or was it breast secondary from an unknown primary? We don't really know. Lungs are particularly difficult because differentiating primary and secondary lung may be more difficult, even with using things like TTF1 staging, because some tumors do still express TTF1. So this was a patient who had, this patient, we did find it was a primary tumor in the breast. We did find the relevant markers, and does show that you can pick up breast cancer with a FDG scan. This patient is a patient who had bone mets from a primary. We never found the primary. They had lymph node disease in their neck and they had bone mets. And that same, this is the breast patient again, and this patient had a FDG avid lesion in the brain. So we always scan the whole brain in patients with carcinoma of unknown primary because we never know what we can find. There was a review from Germany looking at 82 patients who had a true cancer of unknown primary after both radiology and histology, and they found a primary in about 62% of these patients. And we did a review of around about 80 of our patients, which we didn't actually publish, but we found that the results were pretty similar. We found a positive in around about 2/3 of the patients. And what we can say is that if you have FDG avid carcinoma of unknown primary, the prognosis tends to be pretty poor. Very few of these patients live more than 6 months. There's another review in the EJNMI looking at FDG uptake in cups, and they compared it with the post-mortem. And of course, as I said, unfortunately, these patients do tend to get post-mortems because they tend to die quite quickly. And again, they found about 67% of cases they could identify a primary, but almost, because all these cancers by their very nature are M1, they tend not to get treated, but some of them have very small primaries. This was the main sites of primaries. Lung. Now you think you'd find lung because of CT, but there are small lung primaries that are fine. You can find just with FDG, often in the apex. There can be some scarring around the apex in many patients, and that can be misread and not found as lung. The esophagus is second. Again, finding small, almost plaque-like cancers you can find with FDG, and then pancreas, breast, and then the rest was very small percentage. Lung and esophagus were the two most common sites of primary and unknown origin cancers. So moving from FDG, we discussed peptide imaging with single photon and how this was developed. And particularly looking at ways that we could do this better. And the real breakthrough came in 1998 when the Heidelberg group used a gallium generator, which the gallium generator has actually been around since the 1960s, but they used it to successfully label dotatate and started to use this for PET imaging. These became much more available. Gallium generators became more widely available in the mid-2000s, and different centres started to do different trials. This is a trial from my old hospital at the Royal Free in London, and they looked at 44 patients with negative operatory scans or low-grade uptake on operatory scans, but known neuroendocrine tumour. And they found that both studies showed positive uptake, but more lesions were seen with gallium-68 in 18 patients. Indium was more positive in 1 patient, nobody really knows why. Both were very similar in 7 patients. But there were 11 patients out of 44 in which the Indian was completely negative, but the Gallium-68 was positive. And there were no patients where the Indian was positive and Gallium was negative. And they still found 7 patients they knew had metastatic neuroendocrine tumor because of blood markers, which were negative with both. So this is a typical picture that we are used to seeing. So here we have a patient, this is the occultized scan, and there's a bit of disease here, and you can see in the abdomen, but the liver looks entirely clear. But when you do a Gallium-68 dotatate PET, you see multiple liver metastases, and I'm sure all of you have seen similar experience of this. This is one where, again, there was a lesion here in the upper abdomen, which, interestingly, you don't see very clearly on the Gallium dotatate PET, but you can see the lung and liver metastasis very nicely with the Gallium-68 dotatate. So it really does find more lesions than on the octreotide.
Hi, sorry, it's me again. Do you want everyone in the department or just the doctors?
Can you remember, if you're on your phone, can you remember to mute yourself, please?
I don't know.
Okay, I'll try to talk a bit louder. Okay, but do remember that not every lesion is going to be positive dotatate, and particularly those that have a high Ki-67 may not be positive. So this is a patient who was a professor of pathology. So she was very interested in what was found. So this patient had 2 scans done. The first was an FDG PET scan because this patient had a biopsy of a lymph node that shows a net with a high Ki-67. The second one was a dotatate scan that we were doing to see whether or not we could treat with lutetium dotatate. The FDG scan shows widespread nodal disease. The dotatate just showed a single lymph node that was not FDG avid. The patient, being a pathologist, said, "Well, get a biopsy of both and I'll look at them." And when she did so, she found that the FDG avid nodes showed a Ki-67 of greater than 10%, and the dotatate positive node had a Ki-67 of just 1%. So it was very slowly growing tumor. Clearly, the FDG avid disease could kill her long before the dotatate disease, so she had chemotherapy with a good response. My understanding is that when I followed up a couple of years back, which is about 8 years after she had her initial scans and treatment, she'd had a further dose of chemotherapy, but the dotatate positive lesion had completely unchanged after 8 years. So just be aware that you may pick up different pathologies with different traces in your endocrine tumors. And certainly there has been some evidence, again, I'll show that to you next year, that patients who have FDG avid neuroendocrine tumors do less well with lutetium dotatate. There are other derivatives. People have used DOTA-NOC, which picks up different somatostatin receptors and suggests that's better for pancreatic tumors. Then obviously there's PSMA, and these are multiple ligands. There's not a single PSMA, and this attaches to the glutamate hydropeptidases, and I'll show you been useful in prostate cancer. And most recently has been Fappy, which is fibroblast activating protein inhibitor. Now this doesn't actually target the cancer cells, it targets the cells that support the cancer cells. But this is a very new agent which looks very promising. So what about PSMA? Again, this was developed from the Heidelberg group, and the first one was 617, which is the one that's most widely used around the world. And they looked at 37 patients with elevated PSA, and they found that they could find lesions in patients if the PSA was greater than 2.2. And this was 100% of patients if it was more than 2.2. Now, interestingly, more recently, I think partly again because PET scanners have got better, we really now can find lesions with a PSMA greater than 0.5 with PSMA. We're quite disappointed if we don't find lesions with a PSA of 0.5, particularly in those patients who've had their prostatectomy. Oops. So these are some scans from University of Pretoria. So the first one is looking at PSMA. You can see in the primary tumor, this patient has a big primary on the left side of the prostate, and you can see that very nicely. There's also a smaller area of focal uptake of PSMA in the right side of the prostate, which is due to a second site of primary. And this is not unusual because often you get two primaries in the prostate because it's due to what we call field change. This is, an obvious metastatic disease picked up with PSMA again from the University of Pretoria. I think these scans were done around about 2008, 2009, when Pretoria just got their first generator. This is more of the difficult kind of patient we get asked to see. So this patient has had their prostate removed and they have a bone scan. Now this is the kind of bone scan that when you look at it, you go, I don't know. So there's uptake in the shoulder. I don't know, maybe degenerative. There's a spot of uptake in the spine. Could be degenerative, but it's quite focal. Maybe it's not degenerative. What to do? Well, these days, what we do is a PSMA scan. And interesting, this patient was part of a project we had, which is this patient had a PET-CT scan with PSMA. And then when they finished their PET-CT scan, they trotted off to the PET-MR scan, and we were comparing the two sets of scans. But it's an hour later. Now, an hour later with PSMA means 1 hour's less counts, but the PET-MR scanner has really sensitive detectors, so we weren't so worried about that. Now, the PET-CT scan was completely negative, but an hour later, using these more sensitive detectors, we picked up just where that was positive. Now remember, the bone scan was a posterior, so it's on the other side. There is the metastasis. So the bone scan was right. It is a small metastasis. It's very interesting. But of course, we wouldn't normally do a PSMA at 2 hours. We normally do it 1 hour to get the counts. There are new fluorinated PSMAs coming along. There's a couple of those that are going to be licensed. DCFB is one of these that was developed at Johns Hopkins. There's one called 1007, and that was being developed in Boston. And when you look at the two tracers, the differences are meant to be that the fluorinating has less activity in the salivary glands, less uptake in the pancreas, and less urinary excretion. So maybe better for looking at around the prostate, but obviously you still see kidneys. The big advantage of the fluorinated PSMA is you don't need a gallium generator. So if you can get hold of FDG, there's the probability you can get hold of fluorinated PSMA. Not now, but in the future. So the last thing we're going to look at is Fappy. So Fappy has been again known for about 20 years. And there were some papers in the late noughties trying to use Fappy to look for fibrotic disease in retroperitoneal fibrosis and rheumatoid arthritis with moderate success. But again, the German group from Heidelberg thought, cancer cells don't live on their own. They live with, and they develop fibrosis around them to create a structure they can live in. Maybe Fappy will identify this. And the great thing about Fappy is that unlike glucose, it doesn't cross the blood-brain barrier. So you could possibly use it for brain tumors. Because where there is a brain tumor, the blood-brain barrier is breached, so it will cross at that point. And the idea was that maybe also it'd be a bit more cancer specific than FDG. And to be honest, that hasn't actually been proven because all the papers have looked at patients with known cancer and with not a lot else going on. But the other thing is that Fappy may have less specific, non-specific background activity. So you might get a better target to background ratio, which may help you. So this is the structure of Fappy. It's a fairly simple structure. And the structure is open to both being labeled with gallium. You could label gallium in this area here, But also there's a couple of these ring structures that could be fluorinated, and that could be interesting because we could have F18 Fappy, which may enable us to do more Fappy scans around the world. So this is the Society of Nuclear Medicine Imaging Image of the Year for 2019, which was when the first paper was published. And this is a series of different kinds of cancers. Now, to be honest, most of these have got a lot of cancer, so it's easy maybe to scan patients with lots of cancer. And what you need to do is scan patients with a small amount of cancer, and also different types of cancers. But this is a promising agent because we can see the first one is sarcoma. So go along the top, if you can't read the writing, it's sarcoma, esophageal cancer, breast cancer, colon cancer, and lung cancer, all positive. Then there's another colon cancer, head and neck cancer, pancreatic cancer, cancer of unknown primary, ovarian cancer. The bottom line is medullary thyroid cancer, thymic cancer, neuroendocrine tumor, small intestinal cancer, and prostate cancer, all positive with Fappy. So there are two things which are interesting. One is it gives us the possibility that we can scan more patients. And you'll notice that it doesn't have the annoying cardiac and cardiac and brain activity of FDG. It doesn't have the annoying salivary gland and pancreatic uptake of PSMA. It doesn't have the annoying gut activity of FDG or PSMA. So it may give what we call a cleaner image. So this could be a very interesting agent for the future, but we do need to do a lot more research with it. But I would look out for Fappy. And I think the Pretoria group are already starting to work with this agent. So oncology is and will always be a major part of the use of nuclear medicine in the future. We still have a limited role in diagnosis, but maybe new agents will change that. More evidence for staging and restaging. There are increasing developments in PET with new agents coming along, though they probably will need to be fluorinated before we can use them more widely. And Fappy is just one of these interesting agents that's coming along that we may be able to use more widely. So thank you very much for listening. I'm just going to start the recording.